The interpretation of Coombs and Hemolytic anemias. So we see a lot of cases in our OP and IP patients, patient presenting into anemia. Some patients have features of CTDs, connective tissue disorders, where we find LDH elevated or bilirubin elevated or some splenomegaly. We send in Coombs and we interpreted Coombs positive hemolytic. But how do you interpret whether it is a warm autoimmune or cold autoimmune or some paroxysmal cold hemoglobin or a mixed pattern? How do you interpret? So generally and basically there are two types of hemolytic anemia. One is warm, the second is cold autoimmune hemolytic anemia. Warm is mostly mediated by IgG or C3. Cold is mostly mediated by IgM. So they bind at different temperatures. The IgG is generally preferred at a warmer temperature at 37 or something. Cold has different thermal amplitudes where it can bind. So generally most of the warm autoimmune hemolytic anemia, the hemolysis occurs in the extravascular space. That is why there is significant splenomegaly, bilirubin elevation in the case of extravascular hemolysis, that is warm autoimmune hemolytic anemia. Whereas in the opposite side, the cold autoimmune hemolytic anemia, most of the hemolysis occurs in the intravascular space. So that is why you don't find significant splenomegaly or bilirubin elevation. You generally find decreased haptoglobin and increased LDH in them. Whereas in the warm autoimmune, you'll find splenomegaly, bilirubin elevation, LDH will be elevated, but haptoglobin won't be decreased as such. So this is the major differences you see in these cases, and we'll go into the case-based scenarios now. A 24-year-old female presented to OPD with complaints of pedal edema. On an examination, she has pallor and jaundice. And LDH is 420 and total bilirubin is 5, which is indirect in pattern. And HB is 7 milligrams per deciliter. On examination, you find a splenomegaly and peripheral smear showed microspherocytosis. So this is a 24-year-old female. He had complaint of pedal edema and she has jaundice and pallor. So we thought pallor and jaundice is there. So there is an anemia definitely. What is the cause of jaundice? So first time you find a jaundice with anemia, you should always look for any hemolytic anemia is present. Definitely if jaundice is present, definitely that means the extravascular hemolysis is occurring. If intravascular hemolysis is occurring, whatever hemoglobin is that is lies, that binds with haptoglobin and excreted in the urine. Whereas extravascular hemolysis occurs, it converts to bilirubin in the spleen. That is why in the warm autoimmune where preferential extravascular hemolysis occurs, so there is splenomegaly, there is bilirubin elevation. Whereas in the case of cold and G6PD, like part of G6PD or PNH, where predominantly intravascular hemolysis occurs, most of it binds to haptoglobin. There won't be any significant bilirubin elevation. You find decreased haptoglobin and more significant LDH will be there. Elevation in the cold autoimmune hemolytic anemia. So clearly there is jaundice here, pallor is there, mostly extravascular hemolysis is there, and bilirubin is also 5. And this one more point I want to highlight is generally you will always confuse in the B12 deficiency also bilirubin will be elevated, and in autoimmune hemolytic anemia also warm autoimmune bilirubin will be elevated. How do you differentiate with them? Generally in the case of B12 deficiency anemia, the bilirubin won't be elevated more than 3. That is the 3 is the cutoff. And also in the case of warm autoimmune hemolytic anemia, it is generally doesn't elevate more than 6. So 3 for B12, warm autoimmune it is less than 6 in the case of warm autoimmune hemolytic anemia. So anything more than 6, you should look for the any per se hepatology causes, any liver causes are there, any bile duct obstruction is there, any gallstones are there. So this is one more thing. Here it is 5. Generally any hemolytic anemia, it doesn't generally raise more than 6. Generally it is around less than 6 only there. In the case of B12, less than 3 is the elevation. So here 5 is there, indirect pattern is there, hemoglobin is 7. On examination you found splenomegaly, I expected an extravascular hemolysis. Peripheral smear showed microspherocytosis. So especially in the case of warm autoimmune, the classical thing you find in the peripheral smear is microspherocytosis and increased reticulocyte count. So that is one more thing that is found in the case of warm autoimmune. The microspherocytosis is one more the classical picture that is for the peripheral smear. So all these patterns, the splenomegaly, bilirubin elevation, jaundice, and also microspherocytosis, all are suggestive of warm autoimmune anemia. So this might be a case of warm autoimmune anemia. You get a Coombs done. So Coombs generally if we do Coombs, that means we are testing autoantibody against the red cell for IgG and C3. So it detects any IgG or C3, it detects. So if it is positive, that means there is some amount of autoimmunity against the red cell. So then if it is positive, then you again go for monospecific, whether the autoimmunity with IgG or C3 or IgM or IgA. There are monospecific for everything. Like what is the culprit antibody that is responsible for hemolysis? Whether it is IgG, that is warm autoimmune anemia. So C3, it can be C3 can also cause warm autoimmune. Mostly C3 cause warm autoimmune hemolytic anemia only, but sometimes it can cause cold autoimmune hemolytic anemia also. So whereas IgM is mostly cold autoimmune hemolytic anemia. IgA can cause warm autoimmune anemia. So based on the what antibody is present, you can tell what is the pattern of hemolysis also. So you send direct agglutinin Coombs test in this patient, it is positive, and then you send a monospecific for that If it's classical, it is you need not spend monospecific because it's classically looking like extravascular warm autoimmune anemia. So mostly if you send monospecific also, mostly it will be positive for IgG. Mostly it is, most of the cases are positive in IgG only. So then you start the patient on steroid therapy. So then you manage them, and you should always rule out what are the secondary causes of warm autoimmune. So warm autoimmune is mostly related to the connective tissue, that is SLEs, Sjogren's, or some rheumatoid arthritis might be a possibility. So or some cases idiopathic cause like Evans syndrome, where autoimmune hemolytic anemia with thrombocytopenia, where you don't find specific cause in them. So you should always work for what are the secondary causes also in the case of warm autoimmune hemolytic anemia. So a 12-year-old child has developed a history of cough and cold a week ago, now present with the complaints of jaundice and darkening of urine. So this is a 12-year-old child, has history of upper respiratory tract infection and with cough and cold, and now he developed with the complaints of jaundice and darkening of urine. So there is jaundice. So one thing, because of the respiratory tract, the patient might develop jaundice. So that is a possibility, and darkening of urine is also there. So I'll also give a few more details. You send in an LFT and CBP in for this patient. You found out that there is anemia of 6.8 in this patient, and jaundice is around 4. That is also indirect pattern. And CU showed that there is darkening, reddish discoloration of urine is there. You found hemoglobin in the urine. So there is hemoglobinuria, there is also the anemia in this patient, there is some amount of jaundice present in this patient. So this is a classical case of paroxysmal cold hemoglobinuria, which is commonly seen in the case of pediatric patients. So pediatric patient after some respiratory tract infection or something, so they will find some amount of cold hemoglobinuria, paroxysmal cold hemoglobinuria because of the Donat-Landsteiner antibody. So that Donat-Landsteiner antibody is that it generally recover on their own. In a few weeks they will recover on their own. It is a symptomatic management is enough for this patient. So in this patient you classically find a history of upper respiratory infection. After that you find anemia, there is also hemoglobinuria. Sometimes they also tell you the cold related symptoms. Generally in the case of cold autoimmune disease, they will tell classical symptoms of when they are feeling cold, they feel pains or some Raynaud's phenomenon they will tell sometimes. Or sometimes cold related ischemia also can also be done because of the cold cause agglutination of RBC that can cause clots in the blood vessels. That also can be like they can cause obstruction in the capillaries. So that is also a problem. They can tell you classical history of Raynaud's or ischemia during the cold or pains during the cold. So that can also be present in the paroxysmal cold hemoglobinuria. So this is a case of paroxysmal cold hemoglobinuria. So in this patient you send a direct agglutinin test which will be positive, especially for C3 it is positive. So this is a case of paroxysmal, mostly symptomatic management is enough in this patient. Say a 12-year-old boy with the positive direct, let's say this is what I did, direct anti-IgG is positive, anti-IgG C3D is also positive, the complements are positive, IgG is positive. There is monospecifics like IgG is positive, anti-IgG C3D is positive, indirect antiglobulin Coombs test is positive. So generally anytime you check for this Coombs test, no, there are direct and indirect. Generally indirect Coombs test can be positive after transfusion, or sometimes if you give some hematopoietic stem cell transplant is done. So in them that if recently in the last 3 months or something, if some transfusion or transplant is done, in them that can be positive. That's why always direct Coombs test is taken into consideration better. So then you found that RBC were coated with polyspecific positive warm IgG autoantibodies. So specifically IgG autoantibodies are present in them along with complements. So complements are also present. Plasma also containing IgM class autoantibodies were found in 1:64 titers with a wide temperature range of 4 degrees to 37 degrees. So in this patient, Coombs test is positive, both direct and indirect. So direct is what we should take into significance more, because indirect can be positive in the past transfusion or some transplant is done or something. So in this direct Coombs test is positive. Then they did monospecifics. So in them warm IgG is positive, complements are positive, and also IgM is positive at the titer of 1:64 with wide range of temperature from 4 degrees to 37 degrees Celsius. So how do you label whether it is a warm autoimmune anemia? Here cold agglutinins are also IgM is cold. So cold autoimmune cold agglutinins are also positive whether you take it significantly or not. So generally first you go for symptomatology. You always go for symptomatology. Whether you should ask for any cold agglutinin related symptoms. First thing is you ask for any Raynaud's symptom is there, any cold related pains are there, any ischemia is there, any changing of color of hands is there, and also you look for the examination, any splenomegaly is there or not, because splenomegaly is more present in the case of warm autoimmune chlamydia. Then you check for the what is the hemoglobin, what is the bilirubin elevation, because bilirubin elevation is more common extravascular hemolysis. Then you look for LDH, you look for haptoglobin. Generally haptoglobin is significantly decreased in intravascular hemolysis. So you then work it, because if intravascular, both extravascular and intravascular is there, then is a high possibility is a mixed, both warm and cold are present. Because if the mixed symptoms are there, maybe both warm and cold are both present together. So then you look for the This also you check for the what are the monospecifics. Already monospecifics were given. So then definitely warm autoantibodies are present. Let's say in this patient splenomegaly is present, bilirubin is little elevated, and also you found that LDH elevation, haptoglobin is decreased, and also is telling cold related change in color is there. So there is a mixed pattern of both are there. So what antibody, this IgM antibody, what are cold antibodies are present, no? These titers may be positive, not in 1:64 titers may be positive at 4 degrees Celsius. That can be positive in normal people also. What is important in the case of cold agglutinins, that is IgM antibodies, is at what temperature it can, that is thermal amplitude. So this 4 degrees to 37 degrees range is important. Generally, to cause a cold autoimmune hemolytic anemia, this whatever titer is there, that should be significantly present at more than 25 degrees Celsius, so that is our normal room temperature or something, so that it can cause significant hemolysis. At 4, that thermal amplitude is important. So just being a titer positive is not significant enough. Let's say the patient is having 1:64 titers, and but the thermal amplitude, they are only acting at 4 degrees Celsius, it doesn't cause hemolysis much. So only cold agglutinins are present in them. That doesn't mean there is a hemolytic anemia in them. If that antibodies are able to act till 25 degrees Celsius or something, that thermal amplitude can range from 4 degrees to 25 or 37 degrees, so that they can act significant cause hemolysis. So that causes cold agglutinin related hemolytic anemia. So that thermal amplitude is important. So here they mentioned as 4 degrees to 36. That is importance. If it is only 4 degrees mentioned, there are only cold agglutinins are present. That doesn't mean they are causing hemolytic anemia. They are acting till 37 degrees. That thermal amplitude important. That is because that can cause hemolysis. So that is a normal temperature where it can cause hemolysis. That is it's a mixed autoimmune hemolytic anemia. For warm autoimmune anemia, you generally go for initially you go for prednisolone therapy. Second lines are azathioprine. You can use mycophenolate mofetil. You can use rituximab can be given. For emergencies, you can give IVIG management also. But in the case of cold autoimmune anemia, you don't find much of the treatment options per se. But you generally go for avoiding the cold exposure and all. You pre-warm the blood and give, and also ask them to wear proper socks and all. So these are the main management. We will discuss later on what are the treatment options that are present. But steroids are not much shown benefit in the case of cold autoimmune hemolytic anemia. A 60-year-old female presented with the complaints of low-grade fever and has pallor on examination. Peripheral smear showed agglutination and Role formation and increased MCV. DAT was positive and co-agglutinins were positive. So this is a 60-year-old female. She presented with complaints of low-grade fever and has pallor on examination. There is anemia definitely. Peripheral smear showed agglutination, Role formation and increased MCV. So this is a classical description of cold agglutinins. Because why? Because cold agglutinins are formed by IgM. IgM is a very big antibody that can cause clumping of RBC, that can cause binding of RBC, bringing RBC together and cause agglutination. So that is why in peripheral smear of cold autoimmune you find classically agglutination and Role formation, because IgM binds with 5-6 RBC and bring them together, cause Role formation and agglutination. And also because the all RBC together, it can cause false elevation of MCV. So increased MCV also you will find. And also DAT was also direct anti-agglutinin test is positive, and cold agglutinins were positive. And the titer, anyways, the titer anything more than 1 is, then generally if cold autoimmune hemolytic anemia, the titer will be almost 400, 500 will be there. Generally more than 1:64 is significant. And also temperature what it is acting also in one. Generally more than 25 degrees Celsius, the titer will be positive, and also thermal amplitude, that range, that antibody can act till that more than 25 degrees. So in this patient that might be positive. So generally any patient, elderly patient that is coming into with the complaint of cold autoimmune hemolytic anemia, you should always look for any secondary cause. Most common secondary cause in the elderly is any CLL is present or non-Hodgkin's lymphoma is present in the case of elderly. Whereas in the case of children, most commonly mycoplasma infection or infectious mononucleosis. Generally infections are the cause in the case of children people, whereas in the case of adult, mostly should look for lymphomas. Any neoplasms are present that can cause cold autoimmune hemolytic anemia. So this might be a case of cold autoimmune hemolytic anemia. So this is how you evaluate. First you evaluate the if you find the evidence of hemolytic, that is elevated bilirubin is there, elevated LDH is there, you find increased reticulocyte count is there, and also decreased haptoglobin is there, you find some sort of splenomegaly or some CTD features are there, then you get for direct antiglobulin test is done. So if it is negative, consider other cause, alternate cause of hemolytic, any hereditary cause like hereditary spherocytis or G6PD deficiency or thalassemia or sickle cell anemia. You should look for all those causes. So if it is not still you suspect all these not possible, only you are still suspecting that, there is one more method where you use column agglutination method. You should repeat the test with column agglutination method. So and also including all the monospecifics. Generally in this direct antiglobulin test you only check for IgG plus C3. Only if IgG plus C3 related hemolytic anemia is there only, it will detect direct antiglobulin. That is a more common antibody. That is why they check only IgG plus C3. If you have strong suspicion, always check for monospecific for IgG, IgM, IgA and C3, because IgA won't be detected generally. So That is why always, because if IgG and C3 can be detected, and also IgM also required some amount of complement binding. So IgM also will be detected because C3 will be binding along with tag along with it. So most of this IgG and ICM C3 will be detected by direct antiglobulin test. But IgA related hemolytic anemia generally will be missed. That also causes warm autoimmune hemolytic anemia. So if you have any strong suspicion you are sustaining hemolytic anemia, you are not finding any other causes, you should always send monospecific, because that will detect it. And also, especially in the case of, in our case, donatlansterin antibody should also be tested in the case of child with hemoglobinuria. In our case, in our second case, we've seen. So if it is positive, rule out other causes. Sometimes Coombs will be false positive. Randomly you send Coombs, sometimes it will be false positive, especially after some transfusion or some hematopoietic stem cell transplant, or especially in the newborn, especially Rh negative mothers. And also in the case of any chronic liver disease or SLE patients where you don't find hemolytic, there is no anemia, but Coombs will be positive because of generalized autoimmunity in the body. And CLD also sometimes autoimmune Coombs will be positive. So that is why and also in the case of some renal disorders also it will be positive, and sometimes after IVIG also it will be positive. So you need to rule out all these causes, especially in our setup. After transfusion, after transplant, after IVIG, after any chronic liver disease or renal disease is there, any generalized SLE without any features of hemolytic anemia. So if there are evidence of hemolytic anemia, you should always look in the positive way. If they are not there, sometimes false positive, alternate cause of false positive of Coombs should be looked for. So no alternate cause are there, you take it as autoimmune hemolytic anemia. So then you go for autoimmune hemolytic anemia. If direct antiglobulin test, only IgG is positive. If only IgG is positive, you directly go for warm autohemolytic anemia. Let's say it is positive for C3 plus or minus IgG. So complement can bind to IgG. In IgM related also, the amount of complement binding will be there. That is why in cold agglutinin disease also that will be positive, because complement will be utilized in the case of IgM related hemolysis also. So then you do direct agglutination test, that is cold direct agglutination test will be there for the detection of cold autoimmune hemolytic anemia. Then you take for antibody titer. If it is less than 1:64, that is insignificant cold agglutinins, so you should look for other causes. If it is more than 64, then you again check for direct agglutinin test, either C3 or C3 plus or IgG. So if it is present only for C3, that means this IgM is utilizing that C3, that is why C3 is a direct agglutinin test is positive, you label it as cold hemoagglutinin disease. If both C3 plus IgG is positive, like in our previous case where IgG is positive, C3 is positive, IgM is positive, in them you label it as mixed autoimmune hemolytic anemia. So you need to understand the concept that C3 is positive in both IgG related hemolytic anemia or isolated C3 related hemolytic anemia or C3 IgM related hemolytic anemia, because both IgM and IgG uses complements activation. That is why C3 is utilized. So that is why if C3 plus IgG direct agglutinin test is positive, you should label it as mixed autoimmune hemolytic anemia. If only C3 is positive and cold agglutinin is positive, that relates to the cold hemoagglutinin disease. If titers are insignificant, you should always look for less than 8 years, any hemoglobinuria is there, or child has hemolysis, you should always look at donatlansterin for any proximal cold hemoglobinuria. So if it is not there, then you go for warm autoimmune anemia workup only. This is the workup. In brief, you do get that done. That can detect IgG and C3. If it is only positive for IgG, you directly label as warm autoimmune anemia. Then if it IgG plus or minus C3, you check for cold agglutins. If they are negative, workup for paroxysmal cold hemoglobinuria in the case of children. Otherwise, if it is cold agglutinins are positive, you again check for that. If it is IgG plus C3 or only C3. If it is only C3, you attribute that IgM and C3 for cold agglutinin disease. If it is only IgG plus C3 and along with cold agglutins, you label it as mixed autoimmune hemolytic anemia. So this is the titer. So warm autoimmune anemia can be present by IgG only, IgG plus C3, IgA is also possibility. In the case of mixed IgG plus C3, some amount of IgM will be there. Cold agglutins, this is especially this is the most common thing. Usually antigens are positive, antibody titer at 4 degrees North. It can bind at 37 degrees Celsius. This warm autoimmune anemia, that is normal body temperature. Mixed generally more than 36, it has both cold antibodies and IgG plus C3. Mixed pattern will be there. So generally cold antibodies may sometimes will be false negative, there might be low also, but generally they might be positive. Generally may be positive but not very significantly elevated or something. Sometimes they will have both mixed pattern will be there. So they have IgG plus C3, some low titer of cold agglutinin test titers will be present, that is around 1:64. Sometimes they might be less than 1:64 also, but they have related symptoms like both extravascular intravascular hemolysis will be there. They have some cold related symptoms are there, and some mild elevation of cold agglutinins will be there. So that is a positive. This is one more thing. So in this cold agglutinins will be positive, and it is actually usually like an anti-I antibody, and generally titer will be less than 1:64. And usually that they have thermal amplitude less than 25. I already told you to act cause autoimmune hemolytic anemia, cold cold hemoagglutinin disease, that is cold autoimmune related hemolytic anemia, the thermal amplitude should be more than 30 degrees or at least more than 25 degrees in these cases. So that is why if the thermal amplitude is less than 25 degrees Celsius and autoantibody is only mildly elevated, that doesn't cause hemolytic anemia. There only cold agglutinins are present. So there might be normal variant or some related to some clonal disorders or something. That doesn't mean they are causing hemolytic anemia. To cause hemoagglutinin, this thermal amplitude is more than 30 degrees, at least more than 25 degrees, and their titer will be significantly more than 1:64 at least, but they're usually 1:500. So this is one more. They can bind for C3 only, and IgM will be positive. This paroxysmal cold hemoglobinuria, that is C3 related anti-P antibody. Their antibody generally less than 1:64, usually less than 20 degrees Celsius is their thermal amplitude. So this is especially in the case of children. After that, you should check for Donat-Landsteiner antibody. In them, that will be positive because C3 is binding. So these are the most important things. And in the warm, this is IgG and C3, and it's in the cold hemoglobinuria, thermal amplitude is one more important concept you should learn. So these are the classification. Warm, primary is the idiopathic. Secondary, any CLL, lymphoma, solid organs are there. Any infections like HCV, hepatitis B, HIV, and leishmania, tuberculosis, this and all can cause. Like especially hepatitis is most common we see, and HIV related can be caused, CMV can cause, pneumococcal infections can cause, tuberculosis can cause, or any CTD should be looked for, any inflammatory bowel disease should be looked for, sarcoidosis can cause, post-transplantation can cause, common variable immunodeficiency can be a possibility. So these are all possibilities of warm autoimmune anemia. In the case of cold hemoagglutinin, especially primary can be a possibility where there is no cause found. Secondary, especially in the case of elderly patients, always look for CLL or non-Hodgkin's lymphoma or any solid organ malignancy. In children, always look for infection like mycoplasma, any viral infection or infectious mononucleosis. And sometimes after hematopoietic stem cell transplant is a possibility. And this paroxysmal cold hemoglobinuria, where complement-related antibody is there, anti-P antibody is there, where thermal amplitude is less and titers are also not very significant, which is a transient infection which is generally seen in the case of children. After post-infection, some varicella, adenovirus, or influenza, or syphilis, especially of some upper respiratory tract infection, you will find it especially in the children. Mixed same as combination of both. Any primary, secondary lymphoma, SLE infection is a possibility. So this warm autoimmune where you can find IgG is the most common. IgG plus C3 in 56% of cases. Only C3 is 9% of cases. Sometimes IgA is also a possibility in warm autoimmune anemia. In the case of healed coordination, usually IgM is a possibility, and sometimes C3 only is there in the case of 21 to 28 positive. And also only there can also be positive with IgG also. IgG related cold autoimmune anemia is also a possibility, but less likely. So and sometimes only IgG and only C3 is also possible. That is well less, like around 20 to 30% only C3 or only IgG related cold autoimmune hemolytic anemia is positive. Then you should check for thermal amplitude. If they are acting at 4 degrees and 37 degrees, that temperature variation is what it will tell whether it's cold or warm. So that is more important, and this is the one important thing that I can tell. So these are the primary evaluation. You check for full blood count, LDH, haptoglobin, bilirubin, direct antiglobulin test, reticulocyte count, HIV, HPV, anti-DS DNA, ANA, CT abdomen, especially in the case of cold autoimmune disease for any lymphomas and all, bone marrow examination, LFT, clotting, and RFT, LFT, any infection should be ruled out. Direct agglutination test, cold antibody titer should be done in the case, especially if direct agglutination test is positive for C3 and IgG. And then monospecific can be considered, and Donat-Landsteiner antibody, especially in the case of children, should be done. So then also cold agglutinin and thermal amplitude should also be done. Okay. So these are the how you manage warm autoimmune. Mostly you manage with one prednisone initially. You give calcium and vitamin D and folic acid supplementation along with prednisone. Always give calcium, vitamin, because it affects bone health, and also folic acid for the anemia, and also any bone resorption or osteoporosis should always be regularly checked. If not maintained, the other options are azathioprine, cyclosporin, danazole, MMF, cyclophosphamide can be given, and also rituximab can be given. In the case of paroxysmal cold hemoglobinuria, generally supportive care is enough. Sometimes you require, if severe or persistent, you can try steroid therapy. If persistently present or severe anemia is present, you can try steroid therapy. If relapse is present, always for relapse, you can try rituximab. Mixture mostly manages warm autoimmune hemolytic anemia only. In the case of cold hemoagglutinin disease, symptomatic anemia, you give transfusion, and also mainly you can give for supportive care, especially avoiding the cold exposure and giving socks, pre-warming the blood that you will give. And for management, you consider rituximab is the main drug that can be used for cold hemagglutinin disease. Along with that, you can add fludarabine also, especially if there is a clonal disorder. So, but the drug that is used is rituximab for the case of cold hemagglutinin disease. Along with that, fludarabine can be used if there is a clonal disorder. So mixed, as I mentioned, primary it is managed as warm, hot, hemolytic anemia only. So along with that, you give support if you're cold, because the significant in the mixed is only warm. The cold titers are very less significant. Hardly, most of them will have around less than 1:64 only. But the predominant thing is warm, hot, hemolytic anemia. That is why you managed as mostly as warm, hot, hemolytic anemia only. So this is the cold hemolytic. Avoid cold exposure. You give transfusion, rituximab along with clotrimazole. So especially in the pregnancy, a positive DAT test, and the first thing is you can give prednisolone. In the case of pregnancy, you start them on prednisolone therapy, and also you can the first trimester if they start with prednisolone therapy. In second trimester, if they are still not responding, you can try azathioprine, you can try IVIG, you can try splenectomy also in second trimester. And sometimes you should always look for the how is the anemia in infant also, for the fetus also. For that, you check for the in the fetus, you check for the fetal middle cerebral artery flow velocities. You should check. If there is anemia, there will be, in the case sickle cell also use the same phenomenon. If there is increased fetal middle cerebral artery flow, that is indicator there is significant anemia in the patient. So you need to assess if the hemolytic anemia is occurring in infant or at fetus also. For that, you check for, you can't take the blood from fetus. That is why you do a radiological investigation which is fetal middle cerebral artery velocity or flow. So if it is increased, that is suggestive of anemia. That is seen in sickle cell anemia. That is seen in this case hemolytic anemias also. So the autoimmune hemolytic is risk factor for thrombosis, especially antenatal care, and 6 weeks after postnatal you should always give prophylactic, because pregnancy is a procoagulant state and autoimmune hemolytic is a procoagulant state. You might consider giving heparin also in these patients. So this is the treatment. Primarily you give prednisolone. Second line you can give to maintain the second, and based on the stage of pregnancy you can consider IVIG and azathioprine, especially in the second trimester. So after delivery you should always check for jaundice. Is there any, especially in neonates also, you should check for any jaundice, anemia is there, or if there is any direct antiglobulin test should be done. Bilirubin elevation is significantly present. Should always check for neonates also. Should check for autoimmune hemolytic anemia. Thank you.